Usually when we talk about a medical diagnosis, there is this expectation of like absolute crystalline precision,
Yeah.
like engineering.
Right, yeah, like it is a math equation.
Exactly. You break your arm, the x-ray shows that jagged white line fracturing the radius, and the doctor just points at the screen and says, well, there is. That is the problem.
And it is comforting, right, because it is entirely binary. I mean, the bone is broken or the bone is intact, the blood test shows the enzyme, or it just does not.
Yeah, but then you step into the world of neurodevelopment and mental and behavioral health, and suddenly that x-ray machine is, well, it is completely useless.
It really is.
You are looking at a diagnostic landscape that is incredibly murky, where the lines between like a healthy human reaction to a terrible event and an actual pathological disorder just blur together.
Oh, absolutely. It is a massive gray area.
And that is why we are so glad you, the listener, are sitting down with us today, because we are bringing you into a really fascinating conversation. We've got a massive stack of source material today.
A heavy stack.
Yes, very heavy. We are looking at the World Health Organization's exhaustive clinical descriptions and diagnostic requirements, or the CDDR. We have global field study data and frontline implementation reports from Norway, Mexico, Germany, and Canada.
All over the map.
Literally. And our mission today is to decode the monumental transition from the ICD-10 to the ICD-11, specifically the entirely rewritten chapter on mental, behavioral, and neurodevelopmental disorders.
And, I mean, the scale of this transition just cannot be overstated. The ICD-11, which is the International Classification of Diseases, 11th revision, it was adopted in 2019 and effectively went live for global health reporting in 2022.
Right.
But the development process leading up to that moment took over a decade.
10 whole years.
More than 10 years. The WHO Department of Mental Health and Substance Use essentially had to orchestrate the most international, multilingual, multidisciplinary, and participative revision process in the history of psychiatric medicine.
Because they are not just publishing a textbook for, like, a niche medical school class somewhere. This is the fundamental global framework used by 194 member states.
Yes.
This is literally how the entire planet monitors disease burden.
Exactly. And within that global architecture, there are two distinct tracks that we need to mention. The main version used by governments and health ministries is called the MMS, which stands for Mortality and Morbidity Statistics.
That is the one with all the high-level data, right?
Correct. That provides the data for tracking massive global trends. But our focus today is the clinical companion to that, which is the CDDR.
The practical guide.
Right. This was designed specifically to be in the hands of clinical psychologists, psychiatrists, primary care doctors, and, frontline social workers. It is the manual for sitting right across from a real human being who is suffering and figuring out how to help them.
Okay, let's unpack this. Because if you are trying to build a tool that works just as well for, say, a primary care doctor in rural India as it does for a highly specialized psychiatric unit in Toronto, you need a very specific guiding philosophy.
You do. And the WHO anchored this entire decade-long project to two core principles, which are clinical utility and global applicability.
Right.
The ultimate goal was not just to categorize human psychology for some sort of academic purity. I mean, the goal was to tangibly reduce the global disease burden.
Wow, yeah.
And the only way you actually do that is by ensuring health professionals can accurately identify a condition no matter what setting they're in, and then immediately link that identification to effective management and treatment.
Reading through the methodology, it really struck me how different this feels from the past. Like, if the old ICD-10, which came out in the early 1990s, was this rigid, outdated paper map.
Like a huge fold-out atlas in your glove box.
Yes,
Yeah.
one of those atlases that could not account for new roads or traffic jams. Well, the ICD-11 feels like a dynamic, global GPS system.
That is a brilliant way to look at it.
But it begs a massive question for you and me to figure out here. How do you map the human mind when the terrain looks completely different depending on the country, the culture, or the resources available?
Well, what's fascinating here is how the WHO approached that exact problem. Because they did not just lock a dozen elite psychiatrists in a boardroom in Geneva to debate theory.
They actually went out into the field.
They did. They built the Global Clinical Practice Network. We're talking about thousands upon thousands of practicing frontline clinicians from over 160 countries participating in rigorous field studies.
Wow.
And they strictly operationalized what clinical utility actually means in practice.
Meaning they gave it a sort of pass-fail test.
Precisely. If a proposed diagnostic code was scientifically elegant but failed to help a doctor communicate clearly with their patient, well, it failed.
It gets thrown out.
Thrown out. If it did not accurately describe the messy, real-world presentation of the person sitting in the clinic, it failed.
Right.
But most importantly, if assigning that code did not actively guide the clinician toward a useful treatment decision, the code was deemed essentially useless.
Yeah.
Clinical utility means the tool must do the job it was built for in the actual environment where it is used.
Which naturally forces a complete reckoning with how we have been diagnosing people for the last 30 years.
Oh, a total overhaul.
Because if we look back at the older systems, there was this intense, almost obsessive reliance on what I would call checkbox diagnostics.
Yeah, that is the perfect term for it. It was an era defined by incredibly rigid criteria. And, the historical intention behind that rigidity was standardization.
Sure, they wanted consistency.
Right. The medical community wanted to ensure that a diagnosis of depression in New York meant the exact same thing as a diagnosis of depression in Tokyo.
But to achieve that, they created these incredibly strict mathematical formulas for human suffering. Like, you read the old manuals, and it is literally the patient must exhibit exactly 5 of the following 9 symptoms.
Yes.
And those symptoms must have been present for precisely 6 months.
Which creates an immediate severe problem in clinical practice. I mean, the human mind does not operate on a strict 180-day schedule.
No, it definitely does not. Let's walk the listener through a scenario from the clinical source material because it illustrates perfectly why this rigid system is actually quite harmful.
Okay, let's do it.
So imagine you are living in a remote area, and perhaps you rely on a mobile clinic that only comes through your region once a year.
Right.
You have been suffering from profound, debilitating symptoms of a mood disorder. You can't sleep, you can't eat, you're entirely non-functional. But you have only been experiencing this for 5 months.
And the rigid rulebook says the symptoms must last 6 months.
Exactly.
Under the strict checkbox system of the past, the clinician's hands are effectively tied. I mean, they count the days, they look at the criteria, and they have to say, well, you don't meet the threshold for this diagnosis.
And without the diagnosis, you don't get the treatment protocol.
No medication, no therapy referrals.
You are completely boxed out of care because you are 4 weeks short of an arbitrary deadline, even though your suffering is very real right now.
And that is exactly what the ICD-11 CDDR completely dismantles. It shifts away from those rigid criteria and moves to what they call essential features.
It sounds subtle, just changing the name, but it is a massive paradigm shift.
It fundamentally changes the role of the clinician. So, essential features are the core symptoms or characteristics that a professional can reasonably expect to find in all cases of a particular disorder.
Right, the core essence of it.
They describe the essence of the condition, but the WHO deliberately stripped away the artificial precision. They removed the strict symptom counts and the rigid duration cutoffs, unless there was overwhelming, undeniable global scientific evidence that a specific time frame was biologically necessary to separate the disorder from just a normal reaction.
Wait, I have to play devil's advocate here. If we drop the exact symptom counts and we remove the strict timelines, does this not just become a diagnostic Wild West?
Look at the reliability question.
Yeah, like, how do we maintain any sort of reliability across the globe if every single doctor is just relying on their own personal, subjective clinical judgment?
That is the exact criticism that proponents of rigid criteria raised, and the WHO entirely anticipated it. To answer it, they conducted ecological implementation field studies.
Ecological meaning they didn't do it in a sterile academic lab, right?
Correct. They went into routine, daily grind clinic settings across 14 culturally and geographically diverse countries.
Oh, wow.
We are talking about very busy clinical environments in places like Mexico, India, Nigeria, Spain, and Russia. And to test if essential features actually worked, they used a joint rater methodology with real adult patients.
So you have the patient and you have 2 doctors in the room at the same time.
Yes. 2 clinicians are present. One conducts the live interview with the patient and the other observes. But crucially, they score their diagnostic formulations completely independently.
Oh, so they don't consult each other at all.
No talking to each other. And they tested this on the conditions that account for the vast majority of the global disease burden. So schizophrenia, mood disorders, anxiety, and stress-related disorders.
And the hypothesis from the critics was that without strict checkboxes, the 2 doctors would disagree more often.
But the results showed the exact opposite. The reliability of the ICD-11's flexible narrative guidelines was actually superior to the reliability of the older, rigid ICD-10 guidelines.
That is wild. Trusting the clinician's judgment actually made the diagnosis more mathematically reliable.
Yes.
How does that even work?
Because when you force a human being to adhere to an arbitrary checklist, You force them to shoehorn complex, nuanced presentations into ill-fitting boxes.
Right.
A doctor might see a patient who is clearly suffering from severe depression, but only has 4 out of the 5 required symptoms. To get the patient the medication they desperately need, the doctor might subconsciously or even consciously exaggerate a 5th symptom just to tick the box.
Which artificially skews the global data.
Exactly. By providing clear, descriptive narratives of the essential features and trusting the clinician's extensive training, you capture the reality of the patient much more accurately. The doctors agreed more often because they were finally allowed to describe what they were actually seeing.
Which naturally leads us to the next massive evolution in the manual, because once you admit that human suffering doesn't fit neatly into rigid checkboxes or strict timelines, you also have to admit that it rarely fits into rigid yes or no categories.
No, it really doesn't.
So the ICD-11 starts coloring outside the lines, basically, by integrating what the sources call dimensional elements.
The legacy of the ICD-10 was almost entirely categorical. Think of it like a light switch. The light is either on or it is off. You either have the disorder or you absolutely do not.
Right.
With a few minor exceptions, it was a totally binary system. But modern psychology and neuroscience show us that symptoms almost always exist on a continuum.
So for the listener, imagine you were shopping for clothes. The old ICD-10 basically walked you into a store that only offered small, medium, or large.
And if you don't fit?
If you didn't fit perfectly into one of those 3 shirts, well, too bad. ICD-11, by introducing these dimensional elements, is basically offering bespoke tailoring. It takes your specific measurements, so the diagnosis, and more importantly, the treatment, actually fits you.
And we see this applied in several major areas now. First, we have the introduction of severity specifiers where they didn't exist before.
Oh, like what?
Conditions like bodily distress disorder, intellectual developmental disorders, and dementia are now explicitly subcategorized by severity. So mild, moderate, and severe.
Which tells the health system exactly what level of resources that specific patient needs at that exact time.
Exactly. But I would say the most radical example of this dimensional shift is what happened to personality disorders.
Oh man, this part of the deep dive blew my mind.
It is a total structural overhaul. If you look at the old manual, it listed multiple distinct personality disorders: paranoid, schizoid, histrionic, dependent, borderline.
And clinicians notoriously hated using the system, right?
They despised it. Because nobody's personality fits neatly into just one of those boxes.
Human personality is an incredibly complex matrix of traits.
Exactly. Under the old system, patients would frequently present with overlapping traits from 3 different categories. So a clinician would either give them 3 separate personality disorder diagnoses, which is clinically absurd.
Yeah, that makes no sense.
Or they would just throw their hands up and use the unspecified personality disorder code, which provides 0 useful information for the treatment plan.
So the ICD-11 literally erased all of those distinct categories.
They wiped them out.
They merged them into one single unified diagnosis called just personality disorder. And instead of picking a named box, you code it dimensionally.
Yes. First, you determine the overall severity of the dysfunction, so mild, moderate, or severe, and then you add what they call prominent trait domain specifiers.
This is where the bespoke tailoring really comes in.
Exactly. Once you have established there's a personality disorder, the clinician specifies which trait domains are actually driving the dysfunction. Is the patient exhibiting high levels of negative affectivity, detachment, dissociality, disinhibition, or anancastia?
Anancastia, which is like a rigid, obsessive perfectionism.
Yes, very rigid control.
So let's say you have a patient who previously might have been diagnosed with borderline personality disorder. How does this new dimensional system capture them?
Under ICD-11, the clinician would likely diagnose a moderate personality disorder and then add the trait specifiers of negative affectivity, which captures the intense emotional volatility.
Right.
And disinhibition, which captures the impulsive behaviors. It paints a highly accurate dimensional portrait of the patient's actual personality structure without forcing them into a rigid, stigmatizing stereotype.
And it gives the therapist an exact roadmap. Like, you don't just treat borderline generically anymore. You specifically target the emotional volatility and the impulsivity.
Precisely.
And they applied this continuum approach to psychotic disorders as well, didn't they?
They did. Schizophrenia and other primary psychotic disorders now feature specifier scales for symptomatic manifestations. The clinical reality is that 2 people with a diagnosis of schizophrenia might have entirely different symptom profiles.
That makes total sense.
One might experience profound hallucinations but remain highly articulate and social, while another might have very few hallucinations but suffer from severe cognitive decline and a lack of motor function.
But under the old system, they both just get the exact same basic label.
Right. But under ICD-11, the clinician can rate the severity of specific domains on a continuum. They rate positive symptoms, negative symptoms, depressive mood, manic mood, psychomotor symptoms, and cognitive symptoms.
Wow, that is detailed.
Every single domain is rated as not present, mild, moderate, or severe. You get a high-definition, multi-dimensional snapshot of exactly how the psychosis is manifesting in that specific individual at that specific time.
It is just a vastly more compassionate, human-centric way to look at suffering.
It really is.
And speaking of viewing the human being holistically, we need to talk about how the ICD-11 has officially killed the old Cartesian mind-body split.
This is perhaps the most profound philosophical correction in the entire manual. For decades, diagnostic systems, including the ICD-10, were fundamentally built on a false dichotomy. They separated disorders based on whether they were presumed to be organic or non-organic.
Organic meaning the doctors could point to a physical cause in the body or the brain, right? Like a tumor, a brain injury, a genetic anomaly.
Yes, and non-organic was essentially a placeholder for purely psychological. It implied the disorder existed solely in the mind, entirely divorced from the biology of the body.
Which goes back to René Descartes in the 17th century, who famously argued that the mind and the body are two completely different substances. And somehow, that philosophy anchored global medical billing until 2022.
Which modern neuroscience is thoroughly debunked. The pathophysiology of almost every condition is an intricate, inseparable dance between physiological, psychological, and behavioral components. I mean, the brain is an organ. The mind does not exist outside the biology of the body.
So to fix this, the WHO physically restructured the manual. They moved massive categories of human health around to reunite the mind and the body. Let's look at sleep-wake disorders.
Okay, so in ICD-10, sleep disorders were fractured. If you had non-organic insomnia, perhaps triggered by severe anxiety, it was classified in the mental health chapter.
Right.
But if you had organic sleep apnea or narcolepsy, that was classified entirely separately in the nervous system chapter.
Which makes absolutely no clinical sense because chronic sleep apnea causes profound psychological distress and severe anxiety profoundly alters your physical sleep architecture.
Exactly. The physiological and the psychological are inseparable here. So ICD-11 takes all sleep-wake disorders, unites them regardless of their presumed etiology, and houses them in their own dedicated brand new chapter.
And they applied this exact same integrative logic to sexual health, too.
They did.
Under the old system, sexual dysfunctions and sexual pain disorders were totally split. If a woman experienced severe pelvic pain during intercourse, and the doctor couldn't immediately find an anatomical reason on an exam, it was coded as non-organic vaginismus and thrown into the mental health chapter. But if they found an anatomical issue, it went to the genitourinary chapter.
And the danger of that old split is that it encouraged clinicians to just stop looking. If a condition was labeled psychological, doctors might ignore underlying physical factors entirely.
Right.
And if it was labeled physical, they might ignore the profound psychological trauma that often accompanies sexual pain. ICD-11 unifies all of these under a new chapter called Conditions Related to Sexual Health. It forces a holistic approach, acknowledging that sexual health always involves an interaction of physiological and psychological factors.
But I think the most historically significant shift in this restructuring has to do with gender identity. The ICD-11 has completely reformulated what the old manual called gender identity disorders. They have renamed it gender incongruence, and they have removed it entirely from the mental, behavioral, and neurodevelopmental disorders chapter. It now lives in the new sexual health chapter.
If we connect this to the bigger picture, this decision was not made lightly. It was driven by intense global field studies. The core question they asked was, is being transgender inherently a mental disorder? Does the identity itself cause the pathology?
And the data from the sources is crystal clear on this.
Abundantly clear.
The distress and the functional impairment that transgender individuals experience is robustly predicted by external factors. It is predicted by their experiences of social stigmatization, systemic discrimination, and victimization.
The distress is a reaction to a hostile environment. It is not a symptom of an inherent mental pathology. By moving gender incongruence out of the mental disorders chapter, the WHO made a decisive move to reduce the historical stigma that has contributed to massive human rights violations and huge barriers to healthcare for transgender people across the globe.
Now, a listener might wonder, If it is not a mental disorder, why keep it in the International Classification of Diseases at all? Why not just delete the code completely?
That is a great question, and it comes down to the realities of global health financing.
Follow the money.
Right. In many countries, access to necessary life-saving gender-affirming medical care, so hormone therapies, surgeries, specialized counseling, it is entirely contingent on the patient having a diagnostic code.
Oh, I see.
If the WHO deleted the code entirely, health insurance systems would simply refuse to pay for the care. So moving it to the sexual health chapter preserves access to those crucial medical resources while removing the psychiatric stigma.
But hold on. If sleep disorders, sexual dysfunctions, and conditions related to sexual health are all moved out of the mental health chapter, does that mean clinical psychologists and psychiatrists are no longer supposed to treat them? Like, are we telling mental health professionals to stay in their lane?
Not at all. And the CDDR explicitly clarifies this. The restructuring is purely about scientific and anatomical accuracy. Mental health professionals are absolutely expected to continue diagnosing and treating insomnia, sexual dysfunctions, and providing care for gender incongruence.
Okay, good.
The new structure simply ensures that when a psychiatrist is treating insomnia, they are acutely aware of potential respiratory issues. And when a primary care doctor is treating sleep apnea, they are actively looking for compounding anxiety. It just ensures the whole patient is treated.
So they tore down the wall between the mind and the body, but they didn't stop there. They also tore down the walls between age brackets.
Yes, the lifespan approach.
Because ICD-10 used to have these incredibly rigid silos for child and adolescent onset disorders.
It was a very compartmentalized way of viewing human development. The old assumption built into the manual was that certain neurodevelopmental or behavioral conditions were strictly the domain of pediatrics.
Sure.
The implication was that a patient would essentially age out of them or, miraculously cure themselves by the time they hit their 18th birthday.
Which anyone who has ever met an adult with ADHD knows is patently false.
Completely false.
So the ICD-11 implements what they call the lifespan approach. They have entirely eliminated those child-specific groupings. Instead of walling off childhood disorders, every single diagnostic category in the new manual now includes a dedicated section called developmental presentations.
And this is a brilliant structural change. It provides specific, detailed guidance on how a single disorder manifests differently across the entire human timeline, in early childhood, in middle childhood, in adolescence, and in older adulthood.
The examples in the source material are so fascinating here. We finally have explicit, internationally standardized diagnostic guidance for the adult presentation of attention deficit hyperactivity disorder.
Which is huge.
Under the old system, an adult presenting with profound executive dysfunction, chronic disorganization, and severe impulsivity that was literally ruining their career might be misdiagnosed with an anxiety or personality disorder because the ADHD criteria were entirely focused on, like, a 9-year-old struggling to sit still in a classroom.
Exactly. The symptom expression changes as the brain matures and the environmental demands shift. Hyperactivity in a child might look like literally climbing the walls.
Right, physical movement.
But hyperactivity in an adult might manifest as an internal exhausting restlessness or a tendency to constantly interrupt people in meetings. The lifespan approach actually captures that evolution.
They also include adult presentations for separation anxiety disorder and even pica, which is the consumption of non-nutritive substances, like dirt or chalk.
Yes.
We used to think of pica almost exclusively as a pediatric issue, but the CDDR outlines how it presents in adults, often in the context of severe stress or other neurodevelopmental challenges.
The clinical relevance here is just massive. Think about the lived experience of adults who have struggled with neurodevelopmental conditions their entire lives. For decades, they have felt abandoned by a medical system that assumed their struggles would just evaporate in adulthood.
Right, like a switch flips at 18.
Exactly. The lifespan approach validates their ongoing reality. It ensures that continuity of care does not abruptly stop just because a patient graduates from high school. The human timeline is continuous, and now the diagnostic manual finally reflects that.
Capturing the entire human timeline is an incredible feat, but capturing the entire human timeline across the entire globe, that is a whole different level of complexity.
Oh, definitely.
The ambition of designing a single manual meant to work seamlessly across 194 wildly different member states is almost impossible to wrap your head around. How do you account for all the myriad ways human beings experience and express culture without just falling back on lazy stereotypes?
It was recognized early on as one of the most dangerous potential pitfalls of the revision. If you impose a strictly Western Eurocentric lens on global suffering, you will inevitably misdiagnose millions of people.
Right.
So to prevent this, the WHO appointed a specific, dedicated working group on cultural considerations.
What was their mandate, exactly?
They systematically reviewed the global psychiatric and anthropological literature on how culture influences psychopathology for every single diagnostic category. They analyzed how different societies understand illness, how they express distress, and how they seek help.
That is a mountain of work.
It is. And the result of that monumental effort is a dedicated section embedded in the description of every disorder called culture-related features.
And it is not just academic trivia, it is deeply pragmatic for the doctors. It explains how a patient's cultural background influences how a disorder is conceptualized, experienced, and physically expressed in the clinic.
Because what is considered a perfectly normal, healthy reaction in one sociocultural context might be viewed as deeply pathological in another. A clinician simply must know the difference.
Let's dive into some of the specific examples from the CDDR, because this is where the manual becomes genuinely fascinating. Take depression and anxiety.
Okay.
In many Western cultures, a patient going to the doctor for depression will articulate their distress psychologically. They will say, I feel sad, I feel empty, I am constantly worried, or I have lost interest in my hobbies.
But the global data shows that in many non-Western cultures, psychological distress is predominantly expressed somatically.
Right.
Meaning the emotional pain is translated into and experienced as physical pain in the body.
The sources explicitly mention the Chinese concept of shenjing shuaru, which translates roughly to a weakness of the nervous system.
Yes, a patient experiencing profound depression in that cultural context might not mention sadness at all. They might present to the clinic complaining of severe, chronic fatigue, persistent headaches, widespread bodily aches, dizziness, or a feeling of being vexed.
Wow.
In other cultures across Africa and South Asia, patients might describe severe anxiety as heat in the head, a burning sensation in the stomach, or a feeling of insects crawling on the skin.
If a Western-trained clinician is sitting in a clinic in Toronto or London, and a recent immigrant presents with heat in the head and chronic fatigue, and that clinician is not culturally attuned, they are going to order a battery of neurological tests, find nothing, and then dismiss the patient.
They will completely miss the underlying depression.
Or worse, they might misdiagnose the somatic descriptions as bizarre physical delusions.
And that risk of misdiagnosis becomes terrifyingly high when we look at how the manual handles psychotic disorders. The CDDR explicitly outlines how normative beliefs, meaning things that are widely accepted as real within a specific culture, vary wildly around the world.
The text notes that in many parts of Latin America or in southern China, it is culturally normative to expect the spirit of a recently deceased relative to visit the home.
Exactly. Expecting to interact with an ancestor, hearing their voice offering guidance, or even briefly seeing an apparition of them shortly after their death, that is a culturally sanctioned experience.
Right. It is part of the grief process.
It provides comfort, it does not cause social dysfunction, and it is entirely expected by the community.
But if a grieving patient mentions to a clinician who lacks cultural humility that they were talking to their dead grandfather last night, the clinician writes down auditory and visual hallucinations.
Yes.
And suddenly, a normal grieving process is pathologized as a schizophrenic break from reality.
The manual also requires clinicians to deeply contextualize beliefs in witchcraft, sorcery, or the evil eye. In many cultures, attributing sudden misfortune or illness to a curse is a standard, socially accepted explanatory model. It is not a paranoid delusion.
This highlights a critical point about global health equity. The text warns, in very stark terms, that ethnic minorities and migrant populations are historically vastly overdiagnosed with schizophrenia and other primary psychotic disorders.
It is a systemic failure of cross-cultural psychiatry. The field studies highlighted two primary drivers for this overdiagnosis. The first, as we just discussed, is the literal misinterpretation of culturally normative expressions of distress. A clinician hears a cultural idiom and miscodes it as a hallucination or a delusion.
But the second driver is even more tragic.
Yes. The second driver is clinicians fundamentally misinterpreting the very real, observable psychological effects of minority stress, acculturative trauma, and systemic discrimination.
Just imagine a migrant who has fled a war zone, navigated a perilous border crossing, and is now living as an undocumented minority in a hostile host country.
Right.
They might exhibit extreme hypervigilance. They might be deeply suspicious of authority figures. They might express a pervasive belief that society is structurally aligned against them.
And if a clinician evaluates that patient purely through a sterile, decontextualized checklist,
Yeah.
they might label that suspicion as clinical paranoia or persecutory delusion. But the ICD-11's cultural framework forces the clinician to ask, is this suspiciousness a delusion? Or is it a highly adaptive, reality-based survival mechanism for a person living under the constant threat of deportation and intense social exclusion?
Wow.
You cannot diagnose a broken mind if you don't understand the broken world that mind is surviving in.
That is incredibly powerful. And here's where it gets really interesting. It also changes how we look at the social acceptability of suffering.
Oh, absolutely.
The text mentions that in some cultures, observable behaviors like thinking too much are perfectly acceptable reasons to seek out a doctor. But admitting to sadness or loss of pleasure is highly stigmatized. It is viewed as a personal moral failing, a weakness of character, or a lack of faith.
So the patient will never say they are sad. They will come in complaining of thinking too much or having an aching heart.
And recognizing that specific idiom of distress is literally life-saving. If the doctor forces the patient to admit to sadness before prescribing treatment, the patient will leave out of shame. The culture-related future section gives the clinician the vocabulary to recognize the suffering in its local dialect, opening a door to treatment that would otherwise be slammed shut by stigma.
And we see this brilliantly applied in the trauma section as well. Expressions of trauma are deeply localized. The CDDR references ataque de nervios, which is an attack of nerves, a syndrome documented in Latin American cultures following severe trauma or grief.
Right.
It can involve uncontrollable trembling, palpitations, shouting, and sometimes paroxysmal violence or transient dissociation.
The manual also references ihamuka, which translates roughly to lungs without breath, a highly specific post-traumatic syndrome documented among survivors of the Rwandan genocide.
If you try to force the visceral, explosive presentation of ataque de nervios, or the specific panic of ihamuka, into a standard Western checklist for PTSD, the data simply will not fit. You will misdiagnose the patient, and the treatment will fail. The ICD-11 provides the cultural translation key so the global health system can actually perceive the pain it's trying to heal.
It is a beautiful, expansive philosophy. It really is. But, philosophy is just words on a page until you have boots on the ground. We have to look at how this incredibly complex system, with the dimensional scaling, the cultural nuance, the removal of the mind-body split, how is it actually being implemented on the front lines right now?
That brings us to the implementation data, which showcases the massive technological leap of ICD-11. The WHO Family of International Classifications Network continuously gathers data on how countries are managing this transition.
Let's look at the reports from Mexico first. They took a very proactive approach by testing a WHO-developed software tool called Code Fusion with their medical students.
Right, because the ICD-11 is so massive and so detailed, you cannot just memorize it like the old paper manuals. Code Fusion is an advanced search and coding tool designed to assist clinicians in navigating this new environment. In Mexico, they use it to train their future doctors on a completely new conceptual model for quality and patient safety.
The tool essentially forces the user to organize the clinical data into 3 distinct columns before assigning a code. You have to specify the harm to the patient, so what was the actual physiological or psychological consequence?
Exactly.
Then you specify the cause of the harm. And finally, the mode. How did the harm actually happen?
And the feedback from the medical students was overwhelmingly positive. It drastically reduced the time they spent blindly searching for diagnoses. But more importantly, the students reported that using the tool actively improved the quality and safety of the health information they were generating.
Because it forces them to think critically.
Yes. By breaking the diagnosis down into harm, cause, and mode, the system forces a level of analytical precision that directly benefits the patient's care plan.
Meanwhile, over in Norway, the challenge isn't just training new doctors, it is dealing with the ghosts of the past. They have been doing extensive, grueling work mapping their massive national databases of historical ICD-10 codes over to the new ICD-11 architecture.
They are focused on ensuring continuity for both primary data use, which is the direct, ongoing clinical care of individual patients, and secondary data use, which involves massive epidemiological research, quality analysis, and the formulation of public health policy.
The Norwegian authorities noted that their healthcare workers were essentially demanding the transition. The old ICD-10 was just too rigid and limited for modern medical diagnostics. But transferring 30 years of historical health data without losing its integrity is a monumental IT challenge.
And part of the reason that mapping process is so complex is because of the most powerful technical innovation built into ICD-11. It's a feature called post-coordination.
Okay, yes, I wanted to ask about this because it sounds incredibly technical, but it is actually the engine driving everything we've talked about today. This is the ampersand thing, right?
Yep. Exactly, the ampersand. In the old ICD-10 system, a diagnostic code was just a static, prepackaged string of characters. If a patient's complex condition didn't perfectly match one of the pre-existing codes, well, you had to choose a less accurate code.
Right.
But ICD-11 introduces post-coordination, which allows clinicians to dynamically link multiple codes together using an ampersand to build a highly specific, customized composite picture of the patient's condition on the fly.
So instead of endlessly scrolling through a drop-down menu of thousands of rigid codes, hoping to find one that perfectly matches a complex patient, you literally build the code yourself. It is like Lego blocks for medical data.
That is the perfect analogy. The CDVR gives a great example using dementia. First, you take the base stem code for dementia due to Alzheimer's disease, which is 6080.
Okay.
But you want to capture the dimensional severity we talked about earlier, so you grab an extension code. The extension code for moderate severity is XS0T. By linking them together with an ampersand, so 6080 and XS0T, you've instantly created a highly specific data packet that communicates the exact clinical reality.
And the sources show you can use post-coordination for almost anything. You can link the base code for a substance use disorder with a specific extension code detailing the exact chemical the person is using.
Yes.
You can link a bipolar disorder code to the exact phase of the current mood episode. You can link the base code for personality disorder to the specific prominent traits of negative affectivity or disinhibition we discussed earlier.
The team at the Canadian Institutes for Health Information, or CIHI, has been evaluating this exact feature for primary healthcare reporting. Their preliminary results confirm that ICD-11 offers massive advantages precisely because of post-coordination and its underlying database of foundation entities. It allows a primary care doctor to achieve a level of specificity that was simply impossible under older systems.
So if you are listening to this, why should you care about ampersands, extension codes, and post-coordination in a medical database? Why does this technical architecture matter to your health? Well, because by allowing clinicians to build these complex, highly specific data strings, ICD-11 ensures what health informaticians call semantic interoperability.
Semantic interoperability means the data speaks a universal, flawless language across different computer systems, languages, and national borders.
It means if you are traveling and you get sick in Tokyo or Toronto or Timbuktu, the incredibly nuanced, dimensional, culturally contextualized reality of your suffering does not get lost in translation. That complex ampersand code translates perfectly into the local health system, ensuring the doctors there know exactly what you need.
And on a macro level, better data creates better global health policies. When the World Health Organization can look at the global map and see exactly what is happening with high-definition dimensional accuracy, they can identify trends instantly.
Right.
They can see how a specific cultural expression of trauma is manifesting in a refugee population, or exactly how severe the dementia burden is in an aging nation. And they can allocate funding and resources exactly where they are needed most to reduce the global disease burden.
It is the ultimate closed loop of healthcare. Accurate, culturally grounded diagnoses create accurate global data. Accurate global data drives better policies, which ultimately deliver better, more precise healthcare back to the individual patient at the right time, in the right place.
It really is.
As we wrap up this deep dive, it becomes undeniably clear that the transition from ICD-10 to ICD-11 is not just an administrative software update or a tweak to hospital billing. It is a profound, historical, philosophical shift in how humanity defines suffering and healing.
By abandoning the rigid checkboxes of the past in favor of flexible essential features, by utilizing dimensional traits that capture the true spectrum of human behavior, by demanding cultural humility in every diagnosis, and by finally tearing down the artificial Cartesian wall between the mind and the body, the WHO has built a diagnostic model that is deeply compassionate, scientifically rigorous, and fiercely human-centric.
It really is an inspiring evolution. We're finally looking at human beings as whole, complex entities existing within specific cultural contexts,
Right.
rather than just treating them as walking checklists of symptoms.
It is inspiring, but it also leaves us with a critical, almost existential question to consider as we look to the future of medicine. As our diagnostic tools become increasingly flexible, deeply nuanced, and heavily reliant on the subjective cultural judgment of the clinician to capture the messy reality of the human experience, how will future technologies, specifically artificial intelligence and global healthcare, learn to balance this beautiful, necessary human subjectivity with the rigid binary data structures that AI fundamentally requires to function?
Wow, that is a thought to chew on, because at the end of the day, you can't just fix a broken X-ray machine by feeding it better code. Sometimes you have to accept that you are looking at a human landscape that absolutely refuses to be captured in black and white. Thank you so much for joining us for this deep dive. Take care of yourselves, and we will see you next time.